Hey everybody, welcome again to another video. Today I'll be discussing diuretic treatment in the setting of heart failure. I'll be going over this article by Dr. Ellison, published in 2017 in the New England Journal of Medicine. I'd like to give a disclaimer before I begin, letting you know that my interpretation of this is solely my own reading. I want to make sure that you guys do not follow the advice or the information that I'll give in the coming minutes. Make sure you guys consult with your attendings and your seniors before implementing any of this knowledge to any patients in the clinical atmosphere. So I'll be discussing today essentially the pathophysiology of loop diuretics, the pharmacokinetics, characteristics of loop diuretics. I'll be going over the tubular glomerular feedback, as well as glomerular balance, and discussing the importance of loop diuretics. I'll also be going over natriuresis and different type of phenomenon and why it's important for us to understand these when we're giving diuretics to patients. So if you guys could go look at the article and follow along, I'll be going over specific things that I found important in the article. So briefly, the important thing before I begin is we'll be discussing kind of the pharmacologic characteristics of loop diuretics, including furosemide, bumex, and torsemide. These are the agents that we typically use in the wards as well in the ICU. I'll be going over the bioavailability list later, but before I begin, I want to kind of briefly review the mechanisms behind these agents. So going back, if you guys could see here, we see the different pathology or the different anatomy of a nephron. You see the glomerulus, you see the proximal tubules, then you have the descending loop of Henle, then you have the ascending loop of Henle, and then eventually the distal tubule collecting duct. But you see in the thick ascending loop of Henle, you see the macula densa. I'll go over why that's important in a few seconds, but really where we see a lot of the action that's going on is for the loop diuretics is mostly occurring in the tubule lumen of these transporters called organic anion transporters. So a lot of the diuretic medications that we give are actually not, they don't filter through the glomerular filtration. They actually act on the proximal convoluted tubule, not on the not on the glomerulus. So it's actually happening in the ascending portion of the loop of Henle, and it's working on these transporters called the organic anion transporters. So that's why it's important, and we'll go over kind of where you could see resistance of these, because you also have multi-drug resistant associated proteins, and you also have loop diuretics that are attached to proteins like albumin before they get transported here. So there's a setting where you could see resistance if you have low albumin, and we'll review that shortly. But really the other thing that's really important and where a lot of the loop diuretics kind of work with the macula densa is in the sodium potassium chloride cotransporters, or NKCC. And those typically, those always actually occur in the ascending loop of Henle. In the thick ascending loop of Henle portion, that's where you see that loop diuretics actually compete with the chloride, and so you have kind of this regulation of this transporter. So now instead of having the chloride and the sodium going through, you stop that. So now you have sodium that's going to stay in the proximal tubule lumen, or in the thick ascending lumen of Henle lumen, and you're actually going to cause more natriuresis, and patients are going to, like I said, pee out more water, because if you have a hypernatremic osmoles or increased osmolality, you're also going to have increased water as a result of that. So you're going to have water follow the high concentration of sodium. So that's why you have natriuresis, because you're blocking sodium reabsorption in that cotransporter. So the other concept that I want to go over, and it was briefly described in this article was that the loop diuretics obviously inhibit the same transporters on the apical membrane of the macula densa, and they actually stimulate renin secretions. They actually inhibit tubular feedback, all that stuff. So, which actually part of the tubular feedback is part of the, it normally suppresses glomerular filtration. And I want to go over briefly kind of how that happens. And going back to the kind of physiology, if patients have increased if they have hypertension, you're actually going to have an increased renal blood volume, and as a result of increased renal blood volume, you're going to have an increased GFR, and because you have increased GFR, you're going to have more sodium that's going to be filtered out. Once you have more sodium that's filtering, you're going to have increased sodium concentration in the tubular lumen, and eventually it's going to reach the thick ascending loop of Henle, and that's where you start having the macula densa that's going to sense a higher concentration of sodium and chloride. At that point, sodium chloride is actually going to, the macula densa is actually going to release adenosine. Any other part of the body, adenosine actually causes vasodilation. But actually, in the kidneys, it's going to cause vasoconstriction, and it's actually going to constrict the afferent renal arteries, causing feedback of this. So it's going to eventually cause decreased renal blood flow, decreased GFR, to be able to decrease the amount of natriuresis that you're causing. And so the Lasix actually takes advantage of that, and normally instead of having a high, so you have a high concentration of sodium, typically what would happen is the GFR would, the tubular glomerular feedback will ramp up, but a Lasix loop diuretics will actually stimulate renin secretion, and that will inhibit tubular glomerular feedback, causing sodium secretion to not be stopped, and you're going to have a continuation of natriuresis, but eventually there's going to be a limit to how much natriuresis you could get, and I'll talk about that in a few seconds as well. Yeah, but before I begin talking about that, I wanted to kind of discuss the diuretic resistance, and it's a bit lengthy, so I'll kind of summarize it very briefly, but it just boils down to a couple of 5 things that I want to focus is inadequate dose of diuretics, not giving them the right amount, patients who are just not adherent to both their diet or taking medication, and then just also the pharmacokinetic factors. So patients have slow absorption because of just their gut edema. They also have CKD, aging, and drugs causing impaired secretion of the diuretics into the tubular lumen. In terms of the NSAIDs and probenecid, what happens is those 2 medications compete for the anion or the OAT receptors that we talked about, where Lasix are able to act as ligands in that receptor. And then the other one would be patients with low protein in the setting of malnutrition or nephrotic syndrome. If patients don't have protein like albumin, they don't have carriers to be able to send their loop diuretic into the renal tubules. And also patients with low renal blood flow. If you have low renal blood flow, you also will not able to allow the medication to go into the kidneys. And also nephron remodeling, as I will discuss earlier. But something that I'll plan to spend more time with today is hopefully not too long, but the pharmacokinetic characteristics of loop diuretics. And it was something that was also new to me, and I wanted to kind of learn more. But this is really kind of the idea that all loop diuretics have something called a steep dose response curve, in which there's a plateau in the amount of natriuresis that a loop diuretic could provide. Yeah, so the article goes over the concept about a threshold as well as ceiling, and this all has to do with loop diuretic pharmacology. So below the threshold concentration, there's zero efficacy of any loop diuretic, and the threshold is really the concentration that it takes to fully saturate a transporter, whether it's the transporters, one of the 2 transporters that we talked about briefly, and the ceiling is really the maximum amount of natriuresis that a specific loop diuretic could get. And overall, the concept to remember is that diuretic effect really depends on the duration of time that the drug concentrations are above the threshold. concentration. So how long the time, and that's something you see in the graph of B. You see the time that the longer the time the patient's threshold, they are above the threshold, and the more activity that they'll be able to do, and the more the natriuresis will occur. But obviously, all of that is limited if patients have a small ceiling, and that has to do with the loop diuretic characteristics more than the concentration. And so IV administration obviously achieves a higher level in terms of kind of a higher level of plasma concentration because there's more bioavailability. But really, it could still lead to shorter duration of action. Like you see here, it's a sharp increase, but then the length of time might be short. And so, kind of briefly, going to review the different types of duration of effect for furosemide, torsemide, and Bumex. So usually the conversion for Lasix from oral to IV is 1 to 2. For torsemide is 1 to 1, and Bumex is 1 to 1. And bioavailability, there are 10 to 100% for Lasix, and then 80 to 100 for both torsemide and Bumex. Duration of effect is 6 to 8 hours for Lasix and 6 to 16 for torsemide, and Bumex is 4 to 6. But the half-life is small for the Bumex at 1 hour to 1.5. But in general, we don't have to know all the different dose response curves for each medication, but it's important to know that that's something that we should consider when patients have maybe potentially our stop diuresing. It could be one of the two things. Maybe the loop diuretic that we have might have a small ceiling, and with that kind of idea is this other idea of the natriuresis. Is kind of graph C. Was looking at urinary sodium chloride excretion and also looking over time. And there's this concept that obviously, depending on the loop diuretic over time, they're gonna go back to below the threshold. So the natriuresis will stop, and that's kind of the concept that you see here. But once they're above the threshold, which is kind of the line here, they're able to kind of have more natriuresis. But it's really the net. With the yellow, the white is the anti-natriuresis, and natriuresis is the blue. But really, the total natriuresis would be the difference between the two. That's the net, how much net negative the patient will be. But there's also this concept of post-diuretic sodium retention. And really, the concept is basically saying that over time, after several hours of using a dose of loop diuretic, you are going to have urinary excretion, but then that's going to be followed by a period of very low sodium excretion, and that's going to be termed the post-diuretic sodium retention. And that's going to induce a negative sodium chloride balance if you have a more natriuresis, obviously. But then in general, the post-diuretic sodium retention has to do a lot with the dietary consumption of salt, as well as other post-diuretic sodium retention typically offsets the initial natriuresis if the dosing interval is long. So there will be a time if you're not able to keep above the threshold, you'll eventually have post-diuretic sodium retention as well. So that's why it's important to know the half-life, the length of time, because you want to make sure that when you're giving medication, the duration effect is still is not dropped off. So, for example, if patients have Lasix, duration effect could be 8 hours. Is 8 hours. So if you're only giving it to them, every 10 hours, you might miss that window of duration of effect for some of these patients, and they might fall below the threshold. So they might not have positive natriuresis during that time until the next dosage. So that's kind of, there's a lot of other things that we can talk about, but in general, that's kind of like the concepts that I wanted to hammer home. There's other, we're looking at kind of nephron remodeling as a therapeutic target as well, and research is still looking at other different combinations of medications like loop and thiazide type diuretics, but that could lead to like massive natriuresis. And there's also like a small study that's to suggest that oral metolazone when combined with loop diuretics, is as effective as IV chlorothiazide in reducing congestion. So before I finish, I want to kind of briefly go over the study looking at diuretic strategies in patients with acute decompensated heart failure. It was published in 2011, and what it looked at was it was a double-blind randomized trial looking at 308 patients with acute decompensated heart failure, and they randomized them to either received IV Lasix, either by BID, either as a bolus or as a continuing infusion, and then they were going to either give them a low dose or a high dose, and they wanted to just see if there was any difference based on the symptoms and over the course of 72 hours, as well as a change in creatinine. And what they found is really that for most patients, or for among patients with acute decompensated heart failure, there was no significant difference in those endpoints that they were measuring. So it's kind of interesting to know that even a continuous infusion, when compared to just bolus infusions, did not yield any significant difference in terms of what they were measuring. So with that being said, that's the talk that I wanted to give today. I know a lot of it was dealing with pharmacokinetics, but I think it's important for us to understand how certain drugs work, especially when it comes to nephrology, because it's something that, at least in my med school, we didn't get too much training on. So I'm also hoping to improve on my nephrology as well and just understand more pharmacokinetics. So I'll be doing more talks about kind of the physiology, pharmacokinetics of different medications as well, and hopefully you guys will enjoy that because it gives me a chance to also learn when I'm making these presentations as well. So thank you guys for listening. I also want to kind of start changing my channel, making more videos for more geared towards medical students, third years and fourth years, talking about how to do a presentation, bread and butter cases, kind of the workup, not necessarily kind of talking about all these publications and all this evidence, because I think it's good to have a background in terms of the physiology, and so I'll try to go over that as well in the next coming days. Have a great day, guys. Bye.